Welcome to Back in Motion Health Talk, where we dive into the health issues that matter most to Baton Rouge and beyond. I'm Dr. Justin Walbom, chiropractor and clinical director at Back in Motion Disc and Joint. Each week, I sit down with trusted voices from across healthcare to bring you real conversations and practical advice, covering everything from pain and injury to stress, movement, and recovery. Let's cut through the noise and get you informed and get you back in motion. All right. Welcome to the podcast, everybody. Today, we've got a great one for you. We're sitting down with Clint Serafino. He is a physical therapist out of Charlotte, North Carolina, and has a very interesting background and a great story to tell, and I think can benefit a lot of people with his experience, his expertise, and the information he has regarding some unique approaches to healthcare and performance. How are you doing today, Clint?
Awesome. Thank you. Really glad to be here. Thanks for the invitation.
Absolutely. You're doing some great things, and your background has really kind of sparked some thought in how I approach healthcare and how I approach my patients and the integrative approach and how we need to each kind of stay within our specialty and how we can benefit our patients by doing so. Mm-hmm. But you have a unique background. Why don't you tell everybody kind of how you got to where you're at right now?
Yeah, cool. So I went into PT school. I guess really I didn't change my major like a lot of freshmen and sophomores do in undergrad. I knew as a junior and senior in college, like I could probably do this and be with people all day, every day, and help people get better and help them do the things that they want to do. So PT school, I finished that in 2013. Like every new grad, you get out of school and you know a little bit about a lot of subject matter. And so the next thing that new grads do is take continuing education courses. And so I took a handful in my first couple of years out of PT school. And I took a job initially because the person who hired me was like, hey, in our network, we have an orthopedic residency if you wanted to do that. I'm an orthopedic resident mentor. But she was the kind of person where I would take her questions and she would just say like, Clint, just treat the symptoms. Patients get better. And it's like, man, like I want to know why they get better. I want to know what's going on. I want to shorten this timeline. So took the continuing ed stuff and I got kind of hooked into an institute where we took some spinal manipulation courses, I took some dry needling courses, and I finally had not just technical skills to bring to my patient care and to my plans of care, but I also had a framework to understand, okay, hey, these patients who present this way, we could do a couple of tests and you know, based on our interview, you know, they might be an appropriate candidate for spinal manipulation or dry needling or whatever. And I had not just technical skills, but then a framework within which to use them. So several years after PT school, I went through a fellowship program. I have a fellowship in orthopedic manual physical therapy. So that means I'm just a bigger nerd. But through that process, I learned really through direct mentorship, how to interview patients, how to communicate with patients better, tease out and understand what they're telling us, and then make a plan of care that's suitable for them. Not every patient is suitable for the same kinds of interventions. It's not a cookie cutter approach. And I think we can get into this more, but you know, the healthcare market these days is very much high volume. And it's like, hey, I only have 15 minutes with you. Let's do these few things that I think might work instead of actually picking the right intervention. So I've worked for a couple of startup companies. I've had my own clinic for a little while now. But during COVID, my first clinic, all the patients dried up. It was a cash-based clinic, an out-of-network clinic. And you can imagine with the pandemic and everything, patients were like, yeah, I don't really know what's going to happen in the future. I want to hold on to these dollars. And, you know, I'm okay living in this pain because we don't know if we're going to be here for the next couple of years. So I kind of sat on some savings for a few months, and I had a colleague who was standing up a program in the military in Germany. And he was like, hey, I'm hiring a PT. You want to interview? I was like, I want to move to Europe? Like, I guess so. So I interviewed, and in 10 days, I had 3 interviews and a job offer. And it was like, well, I guess I'm moving to Germany. So I was out there in Stuttgart, Germany for 2 years, working with special operations there. And we can dive much deeper into that as you wish. But a really cool experience to be a part of a truly multidisciplinary team. We had PTs working alongside athletic trainers, strength coaches, dietitians. We had a nurse case manager who was our liaison to the med shed. PTs in the military, they have a different scope of practice, if you will. They can do a lot more. So I could direct refer to images. I could prescribe unscheduled meds. I could direct refer to specialty care, neuro-ophthalmology and physiatry and whatever. So a really cool opportunity to unpack more of the direct provider role, not have to wait for a physician to send them to PT. These people could access us at any time. And it was my job then to triage and go, hey, this is something that I can't fix. You need to see somebody different. And it was my primary role then to put them in the right path, which was great. Life happened, life changed. So I came back to the States after a couple of years, and I'm here in the Charlotte market now. Technically Fort Mill, South Carolina, which is this far, 6 inches from North Carolina, Charlotte area. And have my own clinic here called Performance Collective. We've been doing this for a little over a year and a half now, and it's been quite a journey. And really what my absolute goal is to bring a multidisciplinary model that we use in the military into the civilian side. The challenge is the healthcare system isn't meant to keep humans optimally performing. The healthcare system seems to be meant to keep people just well enough that they keep coming back. And so it's an uphill battle. It's certainly culture changing sometimes. Members of my community, the neighborhood I live in, the places I go, people don't know what PT does. And so as a PT trying to serve the community and grow a business and also begin to change parts of the culture, it's a lofty goal, and it's a lot to bite off and chew all at once. But that's, in a nutshell, my story.
That's fantastic. Well, I need a pad of paper in front of me. There's so many things that I want to follow up with in those experiences. First, I guess one of the questions I had working with the military, especially spec ops, are these individuals similar to high performance athletes where they're in great physical condition but always injured?
I would say the top, yes, that's why they're the top, because they can somehow access a part of their brain and body that they can keep on with the mission and with the training to get things done at the detriment of their physical capacity. The unique part about the command that I worked in, it's called a joint operation command. So our joint base was Army primarily, but then Navy, Marines, Air Force all together. So what we saw were a mix of special operations guys, Green Berets, SEALs, but also the enablers, the people in the offices, doing the finance, doing the operation planning and things like that. So I was not directly working with guys who were actively going downrange on clandestine missions. These guys were promoted more officer level, and they were the ones planning these missions. But still, that culture is the same. They're like, their training sessions before we got there were like, yeah, you got a mile run buy-in. We have a 45-minute workout, and it's an EMOM for 45 minutes, and then it's a mile buyout. And these guys are doing this 6 and 7 days a week, plus going on rucks, plus doing their training elements and whatever else. So certainly, it's a different kind of tactical athlete, but it very much is that level that they have to tap into those resources, push through pain, let their bodies compensate until they retire. And then it's like, hey, I'm 75% disabled. Like, how do I undo, 15 to 25 years of this abuse to my body?
Yeah. I remember years ago, I treated, he was a fighter pilot and had, I don't know how many carrier landings, hundreds of carrier landings, and his neck was just like a bomb had gone off because I was so deteriorated from just that sudden impact. And, there is, unfortunately, a lot of that's not undoable. But we're going to get into this because performance. So I think a lot of what you alluded to what you said earlier about a lot of people don't know what a physical therapist does, or for that matter, what a chiropractor does. They have these preconceived notions of kind of the box that we fit in. And for instance, my practice here in Baton Rouge is primarily focused on neuropathies. So we do compressive neuropathies, we do peripheral neuropathies, metabolic neuropathies. Whereas if somebody walked into my clinic, other than if they wanted hyperbaric therapy, for athletic performance or something like that, I wouldn't know the first clue about where to start on optimizing performance, other than kinematics and biomechanics, that type of stuff. Versus what you do a lot of is performance enhancement. Is that right?
Yeah, it's certainly a mix. I think for me, the way that we define performance is like what do you need to do? Like, are you a 60-year-old person with grandkids that can't run around and crawl around on the floor with your grandkids, and that's important to you? Or like, do you have just crippling pain that you can't get your yard work done and you really love to do yard work? So certainly that avatar, certainly people like me, like mid 30s, early 40s, early 50s, where it's like, yeah, I used to be an athlete and I used to perform, but like I'm time poor now. I spend all my time at work and then at home managing home, and like I work out, an hour 3 times, 4 times a week. And it's like, how do I optimize what I'm doing to get the outcomes when I can't spend, multiple hours per day or 20 hours per week in the training facility? So, and then yes, of course, we see athletes. We see I have a couple of pro and high level athletes right now that are really interesting to treat. And it's more so, yeah. How do you help with the timing and the agility and the speed work, and still build a core foundation of activation and strength through an injury, and also then to make yourself more competitive on the field or the pitch or the court.
So what you learned in your military application translates directly to civilian work, and just at a lesser intensity, or are your goals and outcomes the same as they were when you were doing the military stuff?
I think the goals and outcomes always depend on what the patient's goals and outcomes are. The nice part about the command that I worked in, since we had the special operators working alongside the enablers, I didn't see, it was kind of a really good mix of the high performing athletes, tactical athletes that had to keep going at a high level, and also the regular people that are service members sitting at a desk, doing the planning ops, doing the finance, doing the logistics and whatever else. So that experience was more like maybe a traditional clinic, maybe with the mix and the breadth of patient population and avatars, less of just the specific. I wasn't just working with 60 Green Berets in a unit that were going to be deployed. So I think it does carry over to clinic really well. Mostly the multidisciplinary and the functional capacity part, less of the maybe like top tip top of the performance element.
Sure. Do you find that model where you had multidisciplinary, was everybody in the same mindset within that interdisciplinary practice, or was this something that you had to kind of, everybody was shifting people around depending on what they did?
So initially, the team that we had was fantastic. Our team was led by a former Marine and strength coach named Paul Titus. He's what's called the human performance advisor. So he was the liaison between our program and the command, to ensure that we're meeting command standards for fit testing and deployability and whatever else. And one of the things that I really respect about the way that Paul built or structured our program is there were roles, responsibilities, and there were left and right limits for each provider. So what was really cool is, if someone gets hurt in the gym, maybe they see the athletic trainer first, and then the athletic trainer has a particular set of evaluation standards and things to check or whatever, and then she would either treat them on her own, or she would refer them to me for a more thorough assessment or something that's not in her scope. Yeah.
I want to pause you there, because this is something on the civilian side that I see quite frequently.
Oh, really?
Problem that I see.
Yes. Okay.
Whereas like a physical trainer will go kind of beyond their training or understanding, and they'll say things that are maybe to the detriment of their client.
Yes.
Because they're constantly pushing for that performance. So was it different in that setting where there were certain rubrics or standards that they followed, and if it hit a certain point, they would say, okay, now I got to pull in Clint to come take a look at this? Or was it a similar kind of idea where you're seeing people and you go, man, why'd they tell you to do that?
So that's
get hurt.
Yeah, that's what I mean is, from the PT, ATC strength side, we all had an understanding and shared the vision and the culture and the mindset of, hey, each of us are specialists, and rather well-trained specialists in our own discipline. And so like, here are the left-right limits and the parameters for what the strength coach may do on the training floor, maybe some tendon loading stuff for some guy with knee pain or whatever. And then he knew, hey, at this point, like, it's been 3 or 4 sessions now where you're still telling me the same thing. You need to level up to the athletic trainer. Or we had a guy come in with calf pain, and the athletic trainer saw the athletic trainer saw him and was like, this seems like a DVT. Like, this is a clot. And so I looked at the guy, and then Julie referred him straight to the med shed for a Doppler, and sure enough, he had so we each had our very clear parameters. And you're right, it breaks down when each discipline oversteps those parameters, or becomes very detrimental to health, detrimental to performance when you don't understand intrinsically where those limitations should be. And on the civilian side, since there's not really a structure for multidisciplinary teams, unfortunately that happens all the time, and it becomes very territorial. Like, well, my strength coach said, or my trainer said, and it's like, right, I'm not trying to keep you out of training. I'm trying to keep you in training, but you may need to see me for 4 or 10 visits to keep you in training for the next 10 years, instead of just keeping doing what you are doing, which seems to be what got you here in the first place.
Yeah, I'm to be honest with you, I struggle with that, because I know what I know, but it's a hard position to say, this person that I don't know, even though they're trained, right. You know, go ahead. You know, is that because you worked as a tighter team within that framework in Germany?
Yeah, I think the way the team was established, again, that kind of shared mindset, the shared understanding, the shared vision was absolutely foundational to each individual on the team working in, not just in their silo, but working in that kind of crosstalk structure. And then routinely, once or twice a week, we would have group sync meetings to sync up and say, hey, you know, I saw Justin on the training floor. I told him to come see you. You know, Julie, did he come and see you? No, he didn't come and see me yet. Okay, well, the next time I'm going to walk him over to the clinic because he needs you. Or like for me, hey, yeah, this person's leveling out of where the PT is. I'm going to have Julie, the ATC, go through this program with them independently for the next 4 weeks. And so we each had those lanes, but the synchronization of that information is super critical in real time, which is something, you know, I don't have access to, you know, everybody's personal trainer to be able to say like, hey, so-and-so, these patients are ready for X, Y, and Z, or hey, they need to be, you know, still dialed back on these couple of things or whatever. That's what's really lacking.
Yeah. I the takeaway I get from that, or at least one of them, is that when you take the profit motivation out of healthcare, as is in that situation, the goal is the performance or the optimization of health for the individual, or at least from the military standpoint, we want them to be able to pass their, you know, physical demands, you know, what they call it, the PT standards or whatever it is. If we take that financial burden off of determining who's going to take care of this person, we get much better results for the patient themselves.
Yeah, and I would add to that, the med shed, the physicians, the PAs, the specialists, they're so saturated anyway that if I do direct refer them, great, but it doesn't mean they're going to be seen tomorrow. You know, some of the specialists in Germany were in a different city, so you'd have to like get time out of your job to then go, and it was allowed to do it, but you just had to schedule it in your life like everybody else does. So the more that we could do on the conservative, more holistic side, the better, because it eased the burden, because there was no financial motivation for, I want to see those people in clinic and do a procedure and then do another image and then do another injection and then queue them up for a consult for surgery. And that's where on the civilian side, there's the need to retain people in the system to keep that that faucet running of just revenue. So.
But you know, with I've seen since 2012 when the Affordable Care Act was, you know, implemented, we see a lot of specialists retiring. They're not being replaced. Medical schools, not as many applications, although they still have plenty, but there's not enough doctors coming out of medical school or out of PT school or out of chiropractic school to replace the ones that are leaving. And so as a result, you end up with specialists that have 3-4 month waiting lists to get into. In the meantime, you're just suffering.
Yeah, and you're toked up on opiates or some sort of non-prescriptive, non-legal substances to help cope with the pain. And the phenomenon that you're describing is also the same in the PT world. The PT world, they're lowering the standards for graduating PT school, because, and not every school, but many of these schools are, because of COVID and the lapse in everyone's education and whatever else, like the intellectual standard is much different. The intellectual baseline is much different for these applicants coming in, and so to pump them through the system and get them out, they're lowering some of the academic criteria standards to pump them out. And so then you have people who are coming out of the PT world who had a different training than I had, and then they also get disenfranchised in the first 6 to 12 months because you're in a huge volume clinic where you're seeing 60 to 70 people a week. You're getting freaking slaughtered in both patients and paperwork, and then your meetings are all about how do you increase your productivity and number of units per visit, and hey, this net rate was actually much lower this month, but still you guys got to see your 70 people, and it's like the targets are never patients. Patient care and patient outcomes. The targets are always financial.
The challenge I see within my profession, I imagine PT is much the same, is because we're physical medicine, meaning the treatments that we provide require direct physical contact or direct physical involvement of the doctor and the patient. And we come out of school and we end up with this technician mindset, like the ability to perform the manipulation or the adjustment or the exercise properly. That becomes the focus. I'm a good doctor, I'm a good therapist because I can do these skills. But we overlook, and I think that there's a lack of training in the important part of being the doctor, and that is in the exam. Asking the right questions, thorough history, formulating the correct plan of care for that patient. That's all non-tech, that's all intellectual and takes a lot of work in order to be able to do that. But that sets the groundwork for your results. If you don't have a good plan, you're not going to have a good outcome.
Yeah, I was just talking to a colleague of mine in Colorado Springs, and he and I get contacted all the time by other PTs that we know, and they may ask questions and whatever. And, he's like, hey, I ask them, cool, you've done all this stuff. You've done everything you talked about, right? Needling and cupping and manipulation and tool works and adjustments and laser. And it's like, well, what's the problem you're treating? Or what's the dysfunctional tissue? Is it joint? Is it soft tissue? Is it ligamentous? Is it neurologic? Okay, then if you don't know that, then no wonder your outcomes are poor. No wonder you're not gaining any ground, because if you're just throwing poop at the wall, to see what sticks, it's no wonder you're here now asking me what to do on a phone call when I'm not even in your clinic. That you got to go do the hard work first, do the differential, understand with a high degree of certainty what maybe one or two tissues are the most irritable, most symptomatic, and start with those. And I'm not talking about an area of tissue, like what's the dysfunction? What's the dysfunction that you've identified? And then how do you treat it?
And also having the I say courage, but the ethical integrity to be able to say, okay, I can identify the problem, may not be my wheelhouse.
Sure. Yeah.
So then what you're talking about with this performance integration, this ability to say, what's the best place for this patient to be? I'm a neuropathy specialist. Okay. I'm not the best person to help, square up a knee.
Sure.
Okay. So I'm going to send them, you need to go over and see Clint, because Clint has the expertise, and I'm going to send him all your information and he can run with you from there. But in the civilian model, in our sick care model, I was just talking with another physical therapist last week, in fact, in one of my previous podcasts, where the animosity that we get between physical therapists and chiropractors and anybody within physical medicine, to be quite frank, is that we're all competing for the same reimbursements.
Yeah. Yeah. I often say to patients, I guess two things. One, I tell them, look, like I work for you. So, and I play nice with others. So if you want me to talk to your strength coach or your fitness trainer, or if you want me to talk to your chiropractor, like I'm happy to work in tandem. In fact, I work really well in tandem, and I value that. But the other thing that I do, and it takes an intentional effort, is if you're the same in like 2 or 3 treatments, we're going to do a reassessment because I've missed something. Like you should not be the same. You might be worse, and then we know, I've kind of provoked something. But my own that takes humility and intellect and what's the word for that? Like I have to then go on this introspective journey and go, okay, what I thought the first time isn't right. So, or maybe it's not right. So I need to go back to the drawing board, do another reassessment. Cool. And then if you're the same again in another 2 or 3 visits, I'm not your guy. And I'll help you find the next step in the journey. But what I can't do, especially in a cash-based model, is justify you just continuing to come in here for 20 and 30 visits just to hang out if we're not making any progress. And unfortunately, that's what really makes money for people in an insurance model is, yeah, bring them, standard of care is 12 visits. Standard of care for an ACL should be, 30 or more visits over 9 months. And it's like, fine, I get that. But also like, what if we could make it shorter than that? And what if they're better at a higher level, performing at a higher level faster than that? Those are the questions that I try to pose. And I'm not ashamed to say, hey, I got it wrong.
Or consider therapies that are outside of that model.
Yeah, that's right.
There's maybe this will lead into it, but you and I have discussed the application of AI in healthcare a little bit in the past, and one of the things that I see is if we will embrace the ability of AI to diagnose and get our egos out of the way.
Yeah.
I really think, because currently AI is pretty dang good at being accurate with diagnosis. At least their top 2 or 3 differential diagnosis are going to be way more accurate than the average doctor.
Yeah, and I think that's what's scary is it's only going to get better. But I think from a human perspective, if we only rely on AI, we don't get to learn the patterns. We don't get to learn how some things present some way for one patient and not another. Or like, hey, not all knee pain is really knee pain. Not all back pain or neuropathy is compressive neuropathy, right? And it does take a human element, but again, it takes that intentional desire from the clinician to go, I can use AI and I can use other resources, but also like eventually I'm going to work myself out of a job if I don't actually understand what information to put where and how to synthesize it on my own. That's the intellectual piece that I think we talked about previously, where we're not getting that very well in maybe school or in our profession, particularly because of the volume and because of the lack maybe of our own introspection to say, yeah, I need to learn more.
We get lost in the minutia of patient care and aren't embracing some of the newer trends or research that's coming out regarding what we do.
That's right.
AI is a tool that I think that we need to learn to utilize for the betterment of our patient care. Much the same way, Google is a very awesome tool for a doctor and a very dangerous,
That's
can
right.
be a very dangerous tool as well. Particularly, I don't know if you get this. I'll get patients that come in and they've Googled several things and they go like, I've got this, or I've got this, I've got this. I'm like, well, yes, technically that, that search is good, but put in perspective or put in context that may not be completely accurate. So it can be dangerous. I think AI is going to be much the same way in that it's a tool that we have in our belt that we have to learn how to use and use safely and effectively. Go ahead.
Well, I was going to say two things. I did some research with AI. Let's come back to that thought in a second. But there are so many studies out there that show, like on a radiology finding, like patients have arthritis and disc bulge and facet degeneration, and a lot of patients don't have any pain. Their picture shows something that's present, but they don't have any pain. And so it's like, okay, well, if that's the case, if you can have the picture and not have the pain, then just because you have the pain doesn't mean that the picture is the problem. So let's do the harder work now. Yeah, I have, degenerative disc disease. And it's like, okay, well, as we age and we get wrinkles on our face, is that called degenerative face disease? Like, no, this seems to be a natural kind of aging process. So let's figure out what else is causing your pain, because your picture looks, in the context, pretty normal.
Yeah, well, I guess we could debate whether that's normal or not. There's this great movement now toward anti-aging,
Sure.
which used to be more plugged into get a facelift or laser resurfacing or things like that. But now we're seeing, the use of NAD+, glutathione, peptides, IV therapies, and these things are actually showing on a cellular level anti-aging.
Yeah.
So
like
when I see,
telomere length and all that jazz
yeah,
changing. Yeah,
lengthening the telomeres, and if I see a film that shows spondylosis, which I hate the finding that this is degenerative arthritis. I
sure.
will, it's semantics, but I think words mean something. So when you say arthritis, that's not a radiographic finding. Arthritis is a condition. It's inflammation of the joint.
Yeah.
Now, the result of that inflammation may be we have degenerative change or spondylosis, right? We have an alteration of the articular surfaces of the spine. We've got bone spurs. We've got bony bridging happening or something like that. But that is never a normal finding. Something has
Fair.
gone wrong in the functionality of that joint to warrant your body's response to create that.
I think that's reasonable. I think perhaps, as you said, words matter. Perhaps the better way to say that is like it's a piece of the puzzle. It may not be the only piece of the puzzle that we need to reference and look at. So the clinical context certainly matters. But yeah, I retract my statement. Normal is not the right word. I think a piece of the puzzle is a better word picture there.
But that, that's a normal radiographic term, normal study.
Right. Yeah, of course.
Even though there's abnormal things on there.
Right.
But this idea of these newer technology, I really think COVID was bad. Let's get that right out there. But I think it had some very positive pivot points for healthcare. It was rough there for a little bit. But I think that the public generally is more plugged in or more focused on things that can keep them healthy now rather than reaction. Are you seeing that same thing?
Yeah, I think, again, the community that I'm in, it's totally a mix. I think, if you look at a bell curve, right, like you have the early adopters, then you have like the majority. And I think that small percentage of early adopters certainly is growing. But I think still, at least where I currently live and work, it's an uphill battle to figure out, like, yeah, there are things we can do now to give you the longevity in the future. And that's, are you willing to buy into that? Or do you just want the pain control now? But I think that the longevity piece is, and that's what I want to have. I want to have multiple resources at my fingertips to keep living the life that I'm living and the life that I lived in my 20s, right? When I'm 50 and 60 years old. And I think there's definitely a movement, and social media certainly helps that, of course. You can get in front of a lot of eyes for relatively little effort. And that's just unheard of before the pandemic and before, maybe when I got out of school, and I don't even know when you got out of school, but it wasn't it wasn't in 2013.
Yeah. Do you think this are you seeing a generational shift, or is it a general population shift? Because I find there's a lot of, there is some shift in the older population, but there's like this locked in, this is what healthcare is, and they won't shift, versus kind of a younger group that's kind of seen what's gone on and says, maybe this isn't working quite so well.
Yeah, I think the struggle really is in that maybe like middle age kind of bracket, whatever, later 30s to early 60s. Like, you have a group that knows there's a pathway through the medical system to get injections and get procedures done. And then, you also have a group like we have here in Charlotte. I forget what it's called, but it was something about like Healthy Saturdays or something like that. But it was like, come and do like, it was at a restaurant, but it didn't have, they weren't like drinking alcohol, and they didn't have like sugary snacks and stuff. They had like an event that was health conscious and health focused, of like, yeah, we can get together and not drink and still have a good time. Like we see a lot of the, mid 20s, early 30s leaning that way, like making some strategic and intentional changes to give them the longevity, limit the alcohol, keep moving, don't run because you have to, don't push through the pain because it's good for your health. Like, let's figure out how to fix these things. And maybe it's peptides, maybe it's red light therapies, maybe it's something else, not just more anti-inflammatories and more injections.
What of those newer therapies do you incorporate into your practice?
I use H-wave, and it's an electrical muscular stimulation device. I use needling, and I use some red light therapy. I'm really early in the red light therapy game, but we used it in the military setting quite a bit. And I like the idea of having the red light therapy in particular, because the laser people always talk about photobiomodulation and those cute words, but to what you said a minute ago, like we are able to affect change with light, with needles, with stim on a cellular level. And isn't that what we want? We need the cells to signal differently. to message to other cells to make changes, to message to the tissues to repair and regenerate. And that's really, that's what I buy into, and that's kind of the method of my practice. Recently, I've purchased a shockwave. I have not practiced with it yet. I'm still, I guess maybe I'm a mid to late adopter of shockwave, but those are things that I don't want them to be gimmicky. I want to use them intentionally. Like, a stim device, not all electric stims created equal. It's not all the same wave or same type of stim. Not all needling or acupuncture is created equal. So those are the things that I employ perhaps differently than just, yep, come in, I'll put needles in you and I'm going to leave. My tech will take them out when I leave.
Is your shockwave, is it a radial shockwave or is that
radial?
It's radial shock.
Yeah.
So, there's a variety, for those that don't know, there's a variety of different ways to generate a shockwave, and the effect on a cellular level is slightly different, depth of penetration and whatnot. But I am a huge fan of shockwave. Do you use the traditional ultrasound in your practice?
No.
No? Why not? Gonna make some people mad here.
So the first thing that comes to mind is I had a colleague. He was faculty for the fellowship that I went through, and one thing he said that stuck with me is, if you're ever going to set up your own research study, don't compare your research to a control group with detuned ultrasound, because ultrasound always wins. And we've all seen this clinically, where you set up Mrs. Jones on the ultrasound for her elbow because the last PT did it and it was awesome when she had it done previously. You go through the whole process and you're like, dang it, I didn't even turn the machine on. And so you kind of like fiddle, like you're putting stuff away or whatever. Mrs. Jones is like, man, it feels so good. So I've had too many of those experiences where it's like, I don't see the benefit like I do with other interventions for ultrasound, but some people ask for it and some people love it. And so
absolutely,
from a patient value perspective and from an evidence-based practice perspective, that's a piece of it. So like, yeah, if you want some ultrasound, okay, we can go get that done. But I think you also need more modalities, different variety than just ultrasound. So those are my thoughts initially.
Shockwave is like the next evolution of ultrasound. It's we're using sound waves to affect the cellular metabolism, which is really cool stuff. So whether it's a shockwave, whether it's an ultrasound, however you get it there, if it makes a pay, I have a funny story about this. It's not ultrasound in particular, but what you're talking about, where the machine didn't get turned on.
Yeah.
So I had a colleague years ago. He had a patient come in. Patient knew nothing about chiropractic or anything. He came in and this was back in the old days where we had to measure focal film distance.
Okay.
Where you put the patient there and you had to measure the distance and move the tube and all that. You still have to do that, but now it's all, they got digital, but he used a piece of string. So he took the string from the X-ray tube that was measured at whatever 40, whatever the FFD length was, and he brings it out and he puts it to the patient's belly button and the machine, and then he'd walk back there and then he pushed it and he did all the diagnostics and he had him come back for the report. And the patient says, "Whatever you did, Doc Mo, I feel so much better. That treatment there where you put the string and that was amazing." And so what he did is, great, let's go do it again. No, he didn't take the film, but he went back there and he went through the whole thing. And a patient was just pleased as punch. So that was the greatest therapy in the world. There's a lot to be said about the mindset and the desired outcomes that the patient wants.
Yes, and there's a ton of literature on that. Expectation-based outcomes. Are you familiar with the Sackett evidence-based practice concept, the three pillars of evidence-based practice?
No.
So Sackett has said back in the day, evidence-based practice includes what the research papers tell us, like what the white papers tell us, what the clinician's experience is. That's the second pillar, clinician experience. And the third pillar is patient values. So like you as a chiropractor, if you know there's research for a certain condition and you are competent and you've had good experience and you have the expertise to deliver an adjustment, but if the patient doesn't want an adjustment, if they're like, no, I had it done before, it made me worse, it scared me, I don't like all the sounds, I don't like how you twist my neck, like, are you going to have good outcomes if you convince the patient, no, this is the best treatment for you? Like, the patient values and expectations is a major piece of evidence-based practice. Evidence-based practice is how you apply as a clinician your expertise to the patient that you're treating based on the research and the training that you have. And so many of us are like, but I can crack your neck and you're going to feel better. And it's like, right, but if you don't want that cracked, or like if you don't want needles put in you, or if you don't like how shockwave feels, you're probably not going to come back and see me again. And
Right.
let's make decisions that are based on the patient's values. And then the patient values lead to superior outcomes, which is what you're talking about with a guy with an X-ray and a piece of string feeling great.
Yeah. That's why we as clinicians have to have more than one tool. Because if all you got to
Absolutely.
hammer, you can only hammer nails.
Yeah.
And if you happen to try to hammer a screw, you're not gonna make much headway.
Yeah, and that's what's crazy. Again, maybe back to the territorial thing or the interdisciplinary teams idea is like, I have several lenses that I can look through. I don't have all the lenses. My flavor of Kool-Aid, I think, is rather effective, but it's not everybody's favorite flavor of Kool-Aid. And so, again, intrinsically, if you can recognize that as a clinician and you can just humbly say, I'm not the right fit for you, or this isn't the right modality or treatment for you, let's pick something else. That's a huge piece of the puzzle that I think most clinicians across disciplines are just not willing to consider. What if I'm not the right answer for this person?
I agree, and I don't necessarily think that is. I mean, yeah, I'd ideally like us to be able to play nice in the sandbox a little bit better, but I don't necessarily think it's our fault in terms of ego. The system is not set up well for interdisciplinary. For example,
Yeah.
if I see a patient and they have a chiropractic benefit, there's a bleed over between physiotherapy benefits and chiropractic benefits
Right.
in most insurances.
Right.
So if I'm seeing somebody for, say, a herniated disc in their cervical spine, and I'm doing E-stim, I'm doing needles, I'm doing manual therapies, I'm doing adjustments, and I bill that out, I code that out. I'm also bleeding off
Yeah.
benefits for the physical therapist, say if they're recovering from an ACL surgery
Right.
and they've got to go. I now we're fighting over the same benefits, but for different things. It doesn't make sense for the patient.
That's exactly right. Yeah, and that story. This is where like the cash-based model, the out-of-network model, is an option for many, but then they're paying the upfront cost for these multiple providers. But they're doing it intentionally, knowing that, hey, if I tear my ACL later this year, I'm going to have to, pony up some more money for treatment, instead of getting surprised later on that, well, I saw chiro and I didn't realize that all of that was, going to, and now I only have 2 visits left for this fracture or for this ACL. It's like, how is that possible? So you're absolutely right. It's a system built on just not playing nice in the sandbox with others, and it's designed to be siloized.
Yeah, and we're the, I say beneficiary. We're the beneficiaries of the fallout of that.
Yeah,
Because
that's right.
If everybody
Victims.
Yes, the chiropractor and the physical therapist, or even the pain management doctor versus the family medicine doctor or whoever their primary care. We're not getting rich off of this stuff, right?
Right.
It's important to remember that the insurance, healthcare insurance is there, and the people making money off the health insurance are the health insurance companies.
Right.
Now, I don't want to light
That's right.
any bonfires by saying this. The evil insurance companies. I'm not saying that. I'm just saying, if we can get the mindset of individuals to say, okay, I've got this. Health insurance is really good. If you end up with cancer or in a catastrophic accident and you've got to have major reconstruction and lots of inpatient rehab and that type of stuff, that's great, because you're going to hit that out-of-pocket max. You're going to hit that deductible. But I'll tell you what, man, I treat herniated, and for most people, they herniate a disc in their low back and they're out of work and can't hardly walk. Like, that seems like a major life-changing event. But
Yeah.
I can treat that a whole lot cheaper outside of insurance than within an insurance model.
Absolutely. Yeah, that's exactly right. And that's, yeah, I agree. I could elaborate further, but you've said it well. That's exactly right.
Yeah. So how do we take what you saw as an effective model within that military experience and lift that up and drop it in the middle of a civilian population. How can people plug into a system that's effective for their health outcomes rather than the sick care or reactive care model that we're all used to?
I think there's a big culture shift, and I don't know how you and I, as two humans, shift that culture. I think it is slowly shifting. Like we said, like the younger generation seems to be much more health conscious and willing to consider other interventions that are not the typical sick care model. So I think it's starting. Remember from the military conversation, we talked about like there's no financial incentive. So it doesn't help in the military to have to wait in line the providers are not getting paid more to see 60 people a day versus 15 people a day. So there's got to be some system. I don't know the answer, but to take away the financial incentive then allows us all an integrated model, a multidisciplinary model where we can work truly for the patient in the civilian side instead of just working for the service members. There are a lot of things that the military does wrong, maybe, and we may not agree with a lot of some of the policy and stuff around it, but certainly that element, if you have to keep the military deployable, you better believe they're going to figure out the best way to do that. And I think that model, unfortunately, has been tough to pull over to the civilian side. Without it being a financial component, I don't know how you also change the culture.
I think that there's also some drawbacks to it. I think if we took the financial kind of component out of it, now all of a sudden you're leaning more toward a socialist system
Sure.
of healthcare, which also has some problems in that we now get healthcare rationing. We get there's no, I mean, between you and me and the people that are listening, there's a reason that really good doctors are really good doctor.
Right.
It's because they hustle.
Yeah,
they
that's
learn.
Right.
They're out there. They're doing the work. And if we go to this system where I'm not incentivized for my expertise, I'm only incentivized for seeing, this number of people or
Right.
something like that, then all of a sudden the standard of care drops. So
Yeah.
it's this weird system where we've got to find a way to, I'm seeing you to get you better, but not to make, I own a business. I've got to make a profit.
Yeah.
I got to feed my family.
Right.
But excessively doesn't need to be. It needs to be adequate.
Yeah.
Without pissing everybody else off in the healthcare field or whoever their other doctors or physical therapists or how it's this weird balance to do that. And I think the model is shifting toward that. Are you seeing in your market an upcropping of concierge practices?
Yes. Yeah. So, people all the time, like on the mommy groups that Jennifer's involved in and like our neighborhood community groups, they're asking about like functional providers, and they're okay to spend, $150 a month to have this concierge physician or concierge, functional specialist, functional med specialist. That's definitely an up and coming. And I have a response to your thought. I mean, we talked about this years ago, colleagues of mine. It may be that in the future we have, with our insurance benefits, a chunk of money, not an HSA, but a chunk of money. Hey, here's your 10 grand for allied health stuff this year. You can spend it where you want. You can go and see this provider for $500 an hour, or you can go to this provider for $50 an hour, and you can then pick. And maybe that's a way in the future to change how those dollars get spent and where they get spent, instead of making it socialist because I agree. This is the socialist medicine. You lose quality and you lose that hustle for sure.
And that's a really good thought. And I think the data is there to show that if people would spend their dollars in with a good physical therapist or a good chiropractor in performance and biomechanical optimization and neurological health before they have an issue, the overall cost of healthcare drops.
Yeah.
And Medicare's had those numbers for years. It's like
Right.
60% less cost with people that get regular routine care. And it just, I don't know why why actuaries haven't looked at that and say, hey, let's allot some dollars for preventive and maintenance versus reactive care.
Yeah. That's right. I mean, Medicare historically on the PT side doesn't pay for maintenance. So then it becomes an ethical issue because it's like, hey, Mr. Jones wants to keep coming. He likes to do the strength routine and he likes the guidance of having a provider there, even if it's not, whatever, one-on-one, which it should be. It becomes an ethical issue because then you have groups of therapists perhaps that are bleeding those Medicare benefits in a way that becomes super useful clinically to get this person to stay healthy and well, but also is like, there are some pretty clear CMS guidelines that we shouldn't do this thing. So it's super complicated and it's not something that I want to be the one to figure out, but I certainly will advocate for changing the model in a way that we can put preventative health first and not reactive health.
Yeah, and I didn't include this in our conversations before the podcast. Are you familiar, or is there anything changing in PT with the Medicare Modernization Act that's in Congress right now? Are you familiar?
I don't know. I have been out of touch with a little bit of that process because I don't take Medicare, and so I don't have to play in that sandbox right now. So I don't really know much more about.
It's like the tip of the spear, though. Like it trickles down from what Medicare decides, and then Blue Cross decides, and then it's like this cascade. So very interesting stuff. There's a whole bunch in there on changes to chiropractic coverage with Medicare. I still don't think that they're going to cover maintenance. That's like an evil word in Medicare. How dare you maintain your health?
Yeah, I mean, this is like, I saw on Instagram the other day, like a power washing company. And he's like, yeah, I sell a membership, $99 a month, and you get priority scheduling, you get discounts off of these services, whatever. And he's like, yeah, I make a ton of money off a membership. And I think that kind of a model is really useful for your routine check-ins. Like, if you like needles or shockwave, and if it helps you, great. When you have something else crop up, like, great, you can be the member here at Performance Collective and priority schedule and get you in for your little tune-up, and then guess what? You're back to doing pickleball and yard work and whatever else that you want to do. So perhaps some sort of membership like the functional med docs, the concierge docs kind of do, but perhaps that's, again, a way to use those allocated funds, if you will. But otherwise, people are spending money on their healthcare premiums and then also spending money on these memberships and these concierge services because they know that's really what's helping them, and it's maintenance. But it's preventative for the longevity of their physical performance, human performance.
Yeah, I really hope that some of this. I think right now there's a lot of this regenerative medicine stuff and longevity medicine, aesthetics clinics have really plugged into this.
Yeah,
but I think it gets a little bit of a not bad rap, but just people think it's kind of faddish. But a lot of this stuff is just really rock solid research. And it's, I think, going to be fundamentally critical to maintaining our health, particularly with the lack of nutrient-rich foods with the monocrop agriculture that we have. And it's really hard to get a healthy lifestyle these days.
It's costly. And from a provider level, most providers don't really understand how like cell signaling works. And it's a complex, I'm not gonna pretend that I can, I don't have a PhD in this stuff, but I know enough that when you tell the cells what to do, whether it's peptides, whether it's mechanical input, whether it's light, light energy waves, and it creates this photobiomodulation, whatever the things are, like if you understand what you're trying to do from a physical medicine perspective, we're looking at muscles, bones, cartilage, nerves, whatever, but from your system, your GI health, your cardiac health, your renal health, having these kinds of interventions is extremely useful, I think, to figure out how do you change the set point of where we are and allow your cells to function and to heal, instead of just continuing on in your current lifestyle. And there's much more to learn and debate, but you're right, the research is it's pretty strong, and unfortunately not a lot of it is permitted based on the FDA and how we're using peptides. But if we can understand what it's actually doing to fix the problem, I think those are really good solutions to incorporate in the future. And I'm on the very beginning of that journey myself to try to figure out like, what role do GLP-1s play? What role does BPC 157 play? How do I incorporate that? So more to follow on that.
Yeah, there's a lot that's going to be unpacked in the just very near future. And I really tried to steer people away from this idea. I mean, we use this term FDA approved or FDA cleared, which is just a load of garbage. Given that it's just this big lobbying, it's just what do they call that? It's just the revolving door of people that are lobbyists, then end up as officers at a pharmaceutical company or a medical device company or whatever.
Right.
So
it's a broken system, and it's really sad. I mean, like I had even heard, I don't know if this is true or not, but like Merck and Pfizer and AstraZeneca, like they have patents on a lot of these peptides.
Yep.
But why aren't they using them? And I think the perspective that I heard, and I think there's probably some reasonable validity to this. Like, yeah, they know peptides and they know how they work and they know that they're useful, but they also know that it's not a money maker. And so to sleep on those patents and block everyone else from using them seems to be a way to push them to the drugs they're creating that are way more expensive to sell. And that gets into a whole lot of other stuff. I don't want to get canceled, or I'm not even anywhere to be canceled, but
right.
But it's tricky. It's like there must be something to this if all the companies already have patents on this and they're just burying them.
Oh yeah, I think it's very real stuff, but it's that those patents don't last forever, and I really think that they're going to be a key part of maintaining good health, and it should be widely available for people. And I mean, they are relatively now if you want to spend a little money to do it. I wanted to ask you, because anytime I get a physical therapist on, a little bit of my background, like I grew up, my dad was a pharmacist. And my brother was a pharmacist, and I grew up in the medical kind of world, and I never had this idea of allopathic versus holistic. It wasn't a versus thing for me. I had some minor injuries as a kid, and I went to the chiropractor. It made me feel good. That was kind of my introduction into physical medicine. So had I been taken to a physical therapist, it might have been a different path. Sure. But it's much under the same kind of approach and umbrella in terms of physical medicine. And so when I got into chiropractic school, and all of a sudden I was exposed to this political struggle between physical therapists and chiropractors. And the physical therapists were, at least when I was right around the time DPT programs were coming along, because the physical therapist was a master's program and the chiropractors were a doctorate, and the chiropractors could diagnose and order films and do all of this stuff. And the physical therapists were working with the medical profession. And there was this whole physical therapist, we want to be able to manipulate, and the chiropractors shouldn't be allowed to do this. No, there was this, but it was all political. It's all a political, just bunch of BS. So anytime I get a physical therapist where I'm talking to them, I want to know what your understanding or view of the chiropractic profession has been, how it's changed throughout your profession. What's your understanding of what we do?
That's a good question. My opinions and understanding have certainly changed. I mean, and I'm willing to question a lot of things in my life, of course. It's what makes me grow. I value professionals and providers having different lenses. And so I don't know enough about, I know a little bit about the subluxation complex and how, if you have this segment that's pressing on the spinal cord, it's creating different outflow, or it's restricting flow from the neurologic system. And so while I don't really understand how to adjust it or how to treat it, it's also not my lens. I'm not looking at the body through that lens. You are a specialist looking through the body through that lens or another chiropractic lens. And you're driving your plans of care and your treatment interventions accordingly. And I think with that understanding, I mean, there are a lot of PTs who don't know how to load patients. They can help patients feel better. They can't keep them better because they don't know how to. They don't know loading principles for exercise and the difference between isometric and when that's appropriate versus eccentric or whatever else. Mm-hmm. So I think those lenses, as far as how I understand kind of chiropractic, it's I'm okay. I'm not a chiropractor. I'm okay not knowing every in and out of what every chiropractor does, because I don't know every in and out of what every PT does, or every strength coach does. So I'm okay with the discomfort of not knowing. Anecdotally, patients all the time have said both things. Yeah, I saw my PT for 60 visits and I didn't get better. And it's like, why? Or I saw my chiropractor, for 15 years and I love him, but I'm not getting all the way better. And it's like, well, why? So like, I think there's the patient anecdotes that are also, they feed both sides of the argument. Like not every provider is skilled in treating everything. And yet we then sometimes hold on to those patients in hopes that we can finally crack the code. So I don't know if that answers your question. I think
A little
chiropractic,
bit.
yeah,
I've found over the years that we tend to see the worst of each other.
sure,
And so I see, well, the physical therapist wasn't doing enough for me. And you said,
sure.
well, the chiropractor. And then also understanding through, for some reason, I don't know why it is. And I think physical therapy is the same way. We get lumped together. Like all chiropractors are chiropractors, all physical therapists are therapists, and they're doing the same thing. And so
That's
if
right.
this physical therapist failed, all physical therapists suck. And if
Right.
this chiropractor didn't help me, then all chiropractors suck. Don't ever
Right.
go to any chiropractor, because I'm sorry, the second leading cause of death in the United States is iatrogenic death, otherwise defined as caused by medical mistake,
Right.
right?
Yeah. Yeah.
And that is not in dispute. That is a real number out of the Centers for Disease Control, and we don't lump all medical doctors into the same field.
Right.
If I were to say, I knew a person that went to this oncologist and they died, that oncologist sucks.
Right.
Well, I'm sorry, that oncologist deals with high risk pancreatic cancer, and the risk of death is pretty high, not because the oncologist is bad, but because the condition is severe.
Correct.
Right? Surgeons lose more patients on the operating table than a family medicine doctor. Yet we don't lump all medical professionals, all medical doctors into that. Oh, it's a medical doctor, and I had a bad experience with this medical doctor. Therefore, all medical doctors are terrible.
That's right.
Right? And within our professions, there are chiropractors that are chiropractic orthopedists, sports chiropractors,
Yeah. Neurologic.
pediatric,
Yeah.
I'm more of a neurological specialist. And within physical therapy, same thing: wound care, post stroke, and then you got the other, occupational therapy. It's this whole, I think, misconception within the public on what it is we do and how specialized we can become. And sorry, I got on my soapbox a little bit there. But
No, I love that. I totally agree. You're the first person to have said, and I absolutely agree with this. We all get lumped together. Like, what if we took medical out of it and it was like all accountants suck because my accountant I had to pay taxes last year, or like all mechanics suck. It doesn't matter that I own a Jeep. It matters that this mechanic didn't figure out the problem and then the differential's bad and whatever. Like not all mechanics suck. Not all accountants suck. People suck. And so people like you and me are the ones that actually care. We want to get our skills better. We want to learn more, keep growing, keep learning. And you're right. That is a major distinguishing factor. Is we all get lumped in with the same profession, and that's really tough. That's a really good point.
And it's one of the reasons why I started this podcast, was because I see that there's so much, as smart as we are and as expert as we are in our own fields, we're very ignorant of what other people do. I've got a guest coming on very soon who's a pain management specialist. And, most people's perception of pain management is they prescribe opioids.
Yeah.
There's a lot that goes into pain management, and I'm really excited to get into the details with this doctor, because if we as practitioners understand where those boundaries are that you were talking about within the model you worked in Germany,
Yeah.
where we say, okay, I've come up against this boundary. Who else can I bring in to optimize?
Right.
Then if we understand what each other does and where your boundaries are and how they meet mine, now it's not very threatening to say, hey, Clint, I've got this patient. and I really think he could benefit from some performance work. How can we work together?
Right.
Then you're not, well, that dang chiropractor obviously not getting results. That's why he's sending him over to,
Right.
If we understand each other, we're gonna get better outcomes for our patients.
I think we forget that we work for our patients. I think it's like we see them, especially if you're in a model that's not like yours and my model. It's like, yeah, the patients are coming in, referrals are coming in. It's just they're just a number, and that's the way they are in the healthcare system. You see your physician for 6 or 8 minutes, and that includes the amount of time that person has to chart on the patient. And it's like, yeah, you probably don't feel very connected to your healthcare provider if you're only seeing them for plus or minus 6 minutes, and they're going to come in and wave their little fairy dust and tell you the plan, and they're going to leave. We forget that we work for the patients. And again, I said this before, but I play nice with others, and I'm happy to do that. And I've done it at a lot of different levels. And that's the best. Those are the best outcomes that I've had as a clinician, when you're working in tandem with other providers, and not territorial, and not stealing referrals or stealing, I'm not taking food out of your mouth. I want to help us grow and put food in both of our mouths and money in our pockets and get patients better.
This idea of integrated practices, I had another physical therapist on, and his integrated practice deals with mental health and physical therapy. They have some other disciplines coming on board as well, but it's a great model if we can. I think that, coupled with maybe a concierge practice where there's collaboration and crossover and optimization of patient fees.
Yeah.
So they're paying to be a part of this group where there's no hard wall between disciplines. My therapist can talk to my physical therapist, and my physical therapist can talk to my chiropractor, can talk to my medical doctor. And, if there's a specialty outside that, you can refer. But this concept of I'm paying for special access, yet I can still use my insurance if it's applicable.
Yes. Yeah. So, okay. So 2 of the guys that I worked with in Germany, a strength coach, and then the command chaplain, one of the chaplains. The model that I worked in is called PODIF, Preservation of the Force and Family. Mm-hmm. What I described to you previously is the physical performance domain. That's the PT, ATC, strength coach, dietitian, whatever. But we also had social work. We also had spiritual performance, the chaplain. We also had neuropsych and the cognitive domain. And so those are pieces of the puzzle that I didn't tell you about previously, but you hit on it. Like, the holistic model is more than just physically performing. You need the medical side, of course we do, but we also need the psychological, the spiritual, the social side. Like, if you're going through a lot of stuff at home in your social network, divorce or loss or birth of a kid or moving or whatever, like, yeah, probably the other domains, physical performance and maybe your cognitive performance and maybe your psychological health, maybe those other things are declining or affected as well. And those are pieces that, again, we've only talked about the medical side, but to integrate psych and to integrate spiritual health of some kind, whatever it looks like, those are huge factors to helping optimize a person's performance.
There's a lot of research out there to suggest that and psychological, spiritual are kind of married together, with at least within the research that I've read. And you had brought up Peter Attia, which has some phenomenal, philosophical ideas about health. It sounds so floofy when you say philosophical, but it's an important foundation to start from when you're determining how to care for a patient and how to optimize their health and their wellness, to consider all of these things. And I can't address all of them. Like, I've got, if I'm treating a diabetic neuropathy, then I'm treating the diabetic neuropathy. But if that person has a spouse that dies, if you don't think that stress and that trauma of losing a loved one doesn't affect their physical health, you just keep plowing through, or as a professional, are we able to say, hey, you really ought to go talk to somebody and have it not sound weird?
Yeah, and have a resource to point them toward, right? Without them hearing, hey, it's just in your head, or like it's because you're going through all this stuff. Like, no, I mean, we know that's the case. It's in their head because it's in their brain, but it's not. They're not making it up.
Right.
But how do you then create a network of colleagues that you can actually refer to support that? Spiritual also sounds like religious, and so already that's like a block wall that people put up. Like, I don't want to talk to the spiritual side. It's like, no. Like the spiritual and the psychological, they work together. This is overall your entity, your being that we want to work with.
Yeah, I'm really excited. It sounds really weird, but I 15 years ago, I don't think that I would have heard a medical doctor on a radio broadcast or podcast. I mean, there were no podcasts 15 years ago, but talking about the things that Dr. Attia talks about in terms of exercise, nutrition, cardiovascular health, cognitive health, all of these things as a whole. We tend to be very myopic in our system of healthcare, where if I'm a cardiologist, I'm only looking at the cardiovascular system, or if I'm an endocrinologist, I'm only looking at pituitary gland, thyroid, adrenals, I'm only looking at pancreas. I'm only looking at these things, and to have a now broad base and almost universal platform to be able to talk to people about, look, this holistic approach and comprehensive, we've got to find as a group a way to cover all the bases for people.
That's right.
And I don't want to be a mental health professional. One of my best friends is a licensed marriage and family therapist, very good at what he does. But if I had to sit for an hour just analyzing and helping people sort through that, that's not me.
Not my subspecialty.
No, but it's exceptionally important for people to do that, to sort through that. Physical pain and mental health are very closely tied together.
Yes.
Exercise and mental health are tied together. Nutrition and mental health are tied together. Yeah. Cardiovascular health and nutrition are tied together. Like, you can't get rid of any one of those pillars that Dr. Attia talks about without affecting the overall well-being of the individual.
Exactly. These are things like, some of the research that's out there on acupuncture and dry needling is, it's primarily acupuncture literature, but there are parts of the brain that light up when you're in physical pain and when you're in emotional pain. Like, I think it's the anterior cingulate cortex, or the cingulate gyrus. I forget exactly, but like, I could tell you, like, I can flick you and cause physical pain, or I can say, you're so stupid, you're never going to amount to anything, and the same areas light up. And so, like, if we think there's not a neurocognitive element of pain, we're grossly misunderstanding the neurology of how emotional health, psychological health, and physical health are all intertwined.
100%. I'm excited over the next, say, decade to see where the standard of care goes, because I think that we're on the precipice of a shift in how we have to approach patient care. I don't know that our current system is going to survive the next decade. I think there's got to be a shift.
Well, I think the population as a whole drives that shift. Like, we will all start to decline much faster, particularly with all the screen time and all of the brain rot. I don't often sit and just doom scroll, but there are plenty of people who spend hours and hours and hours on a device. And so if you can imagine that, and the brain rot and the changes neurologically, and also when you're just sitting and scrolling, the changes physically, and also then the cardiovascular changes. Like, I think the population health hopefully will begin to drive some of those changes that we're talking about.
I'm very curious what the temporary state of tech neck. Yeah. I think it's going to go away, because I'm old enough to remember the first PCs come out, okay? And the repetitive stress injury back in the day was carpal tunnel. Back when, clack, 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 real typewriters. and there was a lot of resistance and a lot of inflammation created in the carpal tunnel. And now we get ergonomic injuries from being on the computer for 8 hours a day and on your cell phone like this,
Yeah.
and there's what's going to happen when that goes away and everything is integrated,
Yeah.
or you have either glasses or contact lenses that your screen will just be superimposed on. You don't
Yeah.
have to look down anymore. Is technology going to be a aid in achieving better health, or is it going to continue like it has done over the past, say, 20 years, become detrimental to physical health?
It's so funny you say that. I was just in the mall yesterday, which I hate the mall, but we walked past, I forget what store, but there are sunglasses, or there are glasses now that can stream your Instagram reels to the glasses. And it's like, I just saw this yesterday, and it's like, man, I don't use Instagram that much to have it in my glasses all day, every day. And I don't want that either. But to your point, though, there are these technological advances with virtual reality and glasses and other things. Yeah, you're right. Those kind of things with those chronic conditions are going to change to other chronic conditions.
Now, I'm gonna reveal myself as the total nerd that I am, but have you noticed?
No one's surprised. No one is surprised.
Probably true. Probably true. Have you noticed that almost everything that Star Trek came up with in the 60s and through the 90s is a reality?
I don't follow a lot of Star Trek, but that comment does not surprise me at all.
Tricorders, light therapy, personal handheld computer devices, voice recognition, AI. And then I remember a specific episode that I watched as a kid, Star Trek The Next Generation, where they went to this planet and one of the members of the crew brought back this device that they put like glasses over their eyes, and then it would send a signal to their brain to create a massive dopamine release.
Sure. Sounds familiar.
Sound familiar? Yeah. Like it's all there, man. Gene Roddenberry, he was a time traveler.
Yeah. This is, so we'll reveal a lot about me then. The whole, like, whether it's conspiracy theory or whether it's, I don't know the right word, but it does seem like we live in a matrix. Like the fact that there are people who look like current stars and celebrities, that there are old pictures of them from like the 16 and 1700s, portraits and paintings and stuff. It does seem like at some point the code just gets repeated. I don't know if it's a 150-year code. I don't know what the time length is, the time interval is.
In a simulation.
I think there's no evidence we're not living in a simulation. Neil deGrasse Tyson said that, I think, on maybe the Rogan Experience podcast. But it sure feels that way. And if you don't believe it, not you, but if the listeners don't believe it, something will come up this week. The Matrix will upload that stuff to their algorithm, and they're going to experience something that feels like, oh man, we are living in a Matrix.
A glitch in the Matrix.
Ugh. Yeah. Yeah. We can chase that rabbit any other time for sure.
It's a wild time to live in. And for healthcare, it's going to be wild. For technology, it's going to be wild. I don't know what the future holds, but I do know that as of right now, you and I, we just fight the good fight and try to get the best results for our patients we can.
Absolutely. That's the goal. Again, we work for the patients. And I think the starting point is you got to play nice with others. And the other starting point is you got to know where your limitations are. What's the left-right limit? And how do you make decisions that are best for the patient, even if that means they don't come back to see you?
Yeah, fantastic. Hey, I really appreciate you coming on. This has been fantastic.
Agreed.
Been loved having talking to you, and hopefully we get to work together in the future and we can do this again. And more to talk about, more to come with the advent of technology and what's going on in healthcare. Thanks, Dr. Serafino. Appreciate it.
Thanks, Doc. Appreciate you. Had a great time.
Yep. Bye, everybody.